unless I create and I ask you to join. But you let's use this one. So, Mr. Emmanuel will be share your slide, and we can start the class. I'm going to use my phone today, so you let's share. We can start the class. Mr. Emmanuel, are you there? The hypertension slides. Yeah. So before that, before we do that, you know what we do already. So let's start. Let's set the ball rolling. Who is starting for us? Yeah, who is starting for us? You know what we do already. So who is starting for us?
So is it Prince or what?
Okay.
Hello?
Yeah.
Hello?
Mr. Apia.
Yes, sir.
Yeah, set the ball rolling for us. What did you discuss the last time?
Don't you I remember you said hypertension affects almost about 1 billion population in this world.
Let's
And
start.
you were making,
Let's start from the stroke volume and all those ones.
oh, okay. Uh, okay. Then let me see. I should not start in this way. Stroke volume. Okay, so you give an equation that to be able to calculate for the. I'll come back again.
Is that what?
I want to come back.
I've forgotten this one.
About them.
Come again.
I said we have already discussed on the dihistoric and the systolic.
Okay, and what again?
And you even give us a quick example of how to calculate for when the heartbeat is down. What is the meaning? Describing the mechanism of or the
Oh, no, you are actually telling me what we did do.
uh,
What did I say
oh,
about?
okay.
That's what I want to know what you learned. It's not about what we talked about.
uh,
What
okay.
what you learned? Okay, I learned that this is that. You understand what I'm saying?
Okay. And where I learned is what you said. I shouldn't start from that place.
Okay, you tell me what you learned. Tell me what you learned. So does it mean that the first part you were not in class?
I was looking after patients.
Or you forgot it? Or you didn't look through the slide when we finished, you didn't look through the slide.
And that is it. I didn't.
Okay, that's good.
So
You are
it
being
was
honest.
what I captured is what
But
I remember I
do you
wanted.
remember the water bottle analogy, the mineral bottle
Yes,
analogy? Do
yes,
you remember that one?
yes, yes.
Okay, so tell me about that one.
Okay, so I remember you said the when the water bottle is full, uh, and you push when you push half of the I will be doing more. Let somebody bail me and I'll come back.
Nobody's bailing you. Nobody's bailing because you were in class. Or no, at least say one so that somebody will bail you. You have not said any of them. So how does somebody bail you? Mr. Apia,
Yes, sir.
I'm saying that at least you were here. So how does somebody bill you? You are here. At least say something so that if we are struggling, then we can help you. But you've not said anything. So that will be a basis for us to help you. But you have not said anything yet.
Oh, okay.
And so say something. Using the water bottle analogy, what did you say?
You said the stroke volume is when the end diastolic volume. He gave an equation that when the stroke volume is equal to the end diastolic volume, then minus the end systolic volume was may change in and the end diastolic volume minus the end systolic volume, that will give you the stroke volume. And you said that to be able to calculate for the ejection fraction, you need to be able to get the stroke volume over the end diastolic volume times a percentage of 100. That will give you the ejection fraction.
Okay. Okay. But do you understand what we mean by stroke volume? Do you
Yes, sir.
understand? I mean, what is the
Yeah.
stroke?
So that is the question. He said,
So what did I say was a stroke volume? What did I say was a stroke volume? Okay. So
Hello, sir.
yeah.
Good evening, sir.
Yeah. Evening.
So this is Evans. I want to try.
I've not called you.
Hello.
No, I said I've not called you.
Oh, okay, okay. Thank you.
I'm Mr. Pia. It's not like I don't want to call another person. I just want to know whether Mr. Pia has picked something from what we learned the last time.
the stroke volume is said to be the blood that is pumped. That is pumped from the ventricle.
Do you understand?
Okay.
Do you understand?
Yes, sir.
Mm-hmm.
Okay.
So
Sorry, that day movie. To be frank, I must say that I was off because I was looking after some people, so I didn't also revise, and that's why I'm now
okay, no problem.
thinking about the bush.
Okay, any other person to help? Evans.
Hello, sir.
Yeah.
Good evening, sir.
Good evening.
So the last time we talked about stroke volume, and we said that is the amount of blood pumped out by the heart's left ventricle per minute, per beat. Yeah, per beat.
Okay.
So it's like how much blood your heart squeezes out each time it squeezes. We also look at the importance of stroke volume.
Contract. It's contract.
Hello, sir.
The word is contract. The word is contract.
Contract.
Yeah.
Oh, okay. Thank you. So we also look at some importance of stroke volume. Hello.
Okay, I'm listening.
Oh, okay. So stroke volume help us assess how well our heart pumps blood. So if it's low, it means the heart is not pumping enough blood. So if the heart is not pumping enough blood, you can use this stroke volume to diagnose conditions like heart failure. Yes. We also talk about cardiac output. And we say that cardiac output is the volume of blood the heart pumps per minute, and is calculated as heart rate times stroke volume.
Evans, are you reading to us?
Are you looking to
Unless I'm checking it. I am checking. Bye.
What are you doing? Anyways, let's continue. Any other person? One more person.
Hello, Doc. This is Kingsley.
All right, let's have you say.
Yeah, the other time we learned that using the water bottle, we learned that when the water bottle is squeezed, the water that comes out of it, or the drop that comes out of it, is the what we call the diastole. So anytime that the heart pumps, the blood that is pumped out by the heartbeat is what we call the diastole.
No,
And by hello.
no, hold it there.
Hey, Mr. Boybeji, he has already even explained it when I made wrong, and you're repeating it.
The diastole is not the blood that is pumped out.
That is when the water bottle is squeezed. The water that comes out.
That one is the stroke volume.
Yeah, that's the soap one, yes.
So the
And hello, should I continue?
continue.
So for what we learned, it means that if somebody, for instance, is suffering from something like bradycardia, that is for research I did. Bradycardia, which means the heartbeat is low. It also will imply that the person's diastolic will be low because the heart will not be pumping sufficient blood at the time. Thank you.
Mr. Gabriel, it's your microphone. Mr. Gabriel, please help us with your microphone. Hello.
Any other person?
Mr. Gabriel. Mr. Gabriel, please your microphone.
If it's not working, then you take him off. You join later. Lady Zuzu. Zuzu.
Yes, sir. Sir,
Tell me
sorry, it's
what,
a mistake. It's a mistake from my hands.
no, tell me what you learned the last time. Tell me what you learned the last time. What did you learn in class last time?
He has gotten you. Answer.
Lady Zuzu,
Uh,
what did you learn last time? Hey, lady, are you there?
please, I'm here.
So tell us one thing. What did you learn last time? Anything you learned? Anything you heard last time? Wow. Are you saying you didn't learn anything, lady?
I did.
So tell us some. Were you in class when we were talking about this? When we were discussing the water bottle something?
Yes, I was, but to be honest, around that time I was a bit distracted.
So where were you active? Which of them were you active in?
Well, I mean, from the early.
Well, then you guys will not get anything from the classroom. Because if you are here, like, I mean, you put a phone on, but you are doing something else, and your concentration is not here, you can't even remember one, then there's no need for the classroom. Because we should be able to assess what we have told you, what we have learned. It was just on Tuesday, right? This one was just Tuesday, right? Okay, Madam Ingrid. Ingrid.
Yes, sir.
Let's have you. What did you hear last time?
Yes. Good afternoon, sir.
Come again.
Okay. Well, you know what I learned that first of all, stroke, the reference to stroke has nothing to do. Can you hear me?
No,
Hello?
we can't hear. Yeah.
Right. So we learned that first of all, the reference stroke. When we talk about the stroke volume, it has nothing to do with the condition of having had a stroke. Just to say that part. Yeah, pay attention. So anyway,
Thank you.
the stroke volume, you use the example for us to understand.
No. I can't get you. I can't get you. Your network
A
is breaking.
plastic bottle
Mm-hmm.
that is filled with water,
Okay.
and the you fill the bottle with water. Oh no, no, can you hear? Right. So
Yeah.
use the example to understand of the heart being a bottle. You can hear me? Okay. So you use a plastic example of a plastic bottle being filled with water. There's a loud noise somewhere. But anyway, can you hear me? Hello? Hello? Right. So anyway, you fill the bottle with water. And when you squeeze the water, the water that gets displaced. I can hardly hear because of that. But anyway, when you squeeze the bottle, the water that gets displaced, the remaining is what stroke volume. The amount of blood that is pumped by each vent. Can you hear me, please?
No.
We cannot hear you clearly.
To hear me?
And also,
No, we
Mr.
can't hear
Harry's
you.
microphone is on.
Oh,
So it's giving us
oh
a
no.
feedback.
So it's okay. You put it on. Put it on hold. When the network is fine, I'll let you talk. Okay. Mr.
Okay, sir.
Oh,
Menu Charles. Let's
Okay,
hear
sir.
from you. Menu
thank you.
Charles. Menu Charles.
Okay, sir. Good evening.
Yeah.
I also learned about the stroke volume. The stroke volume is the amount of blood or the volume of blood that the heart injects or the ventricles inject into the body system through the aorta. So we said there are some factors affecting stroke volume. Factors that affect stroke volume. One is venous insufficiency.
Okay.
When there is a low venous return to the heart, that means it will affect the stroke volume also. So that is what I learned.
That's a very good one. That's a very good one. We actually said that. Thank you very much. Yeah.
Okay, sir.
Mr. Who's talking? Mr. Pierre?
Mr. David.
All right, let's have you.
Okay. I learned what we learned the other time is the diastolic volume, the systolic volume, and the stroke volume. So the diastolic volume is the total
blood the heart received, or the total blood the heart is filled with. And when if you come to the stroke volume, is the quantity of blood the ventricles spilled off, and the remaining volume becomes the systolic volume. That's what we've learned.
That's fine. That's fine. That's a very good observation. It's a very good observation. The remaining volume becomes you said the remaining volume becomes what? The systolic volume.
The remaining one becomes the systolic volume, sir.
Yes. So that is the end systolic volume.
Yes, and systolic volume. And we've also learned about the functions affecting the cardiac system, or the factors affecting the cardiac system.
Okay.
And we've spoken about the preload, and we've also talked about the electrolytes, as well as the contractility. Yes, that's what we've learned about.
Okay, that's fine. That's a very good one. Do you know something? You guys are mature students, and with mature students, you don't learn like normal students, like young students. You people, all you have to do is that when we are done with class, find time to look through the slides, kakra. And even say, like you should be recording. So when you record, even if you are in your consulting room and you are not able to look through it, you can even put the recording on this one on play, so that you at least you'll be listening. Mature students, you don't learn like regular students or like young students. You are mature students, so your ability of grasping is not so high like the regular students who are always in class and learning about the thing, going for mining, learning about the thing, doing class tests, doing exercise around it. You, when you learn, you leave it down to the next time again and go and pick it up. So the best you have to do is that when we learn in class, then you do what? At least go through. You understand? Maybe if you have this class before, maybe in the evening or tomorrow morning, try as much to get some few minutes to go through it. This is what we taught, this is what we taught. And because it's fresh in your mind, you'll be able to remember. But if you leave it down to the next class, you forget everything. But at least I'm happy few of you have been able to answer it. But Lady Zuzu and Mr. Apia, you owe me. Yeah, for not doing
Okay, I hear. I will do myself.
Owe me on your next class. I will not forget to.
Okay, maybe.
So if I mention your name, I'm going to be on you to give me an answer. Like Mr. Apia was doing, Evans wanted to intercept. No. If I mention your name, the names there are plenty. If I mention one, all right. So I can see Mr. Kenneth Opoku, Kumsin Daniel, Kwame Okra, Joseph Ej Boaten. You are all here. Henry N.K. Kwe. All right. Today's class is going to be a nice one. Yeah, so we talked about ejection fraction, we talked about cardiac output. So we are saying that just a brief recap. I made you know that let's take the heart, particularly the left ventricle of the heart, as the what? As the bottle. Liken it as a bottle. Lady Zuzu, please listen. Liken it as the bottle. Now, if you have a bottle of water, a sachet, a mineral water, the flexible one, the one you can squeeze. If you contract the middle of the bottle, you realize that if the bottle is full, if you contract the middle of the bottle, you realize that some amount of water will be displaced, will pour out of the bottle. So let's liken it to, or let's associate it to the heart. So your contraction of your pressure of the bottle is just like the heart contracting. So when the heart contracts, the amount of blood that left out of the bottle that fell off is the same like the amount of blood that leaves the ventricle and enters the aorta. You understand? Just like how Mr. David said. And enters the aorta. Now, we are saying that if you want to know the stroke volume, if you want to know the amount that left the blood, that left the heart, we are going to calculate the amount that was already in the heart, the amount that was there, the amount that was there before the contraction. Minus the amount that was left after, the leftover. So it's going to be the full minus the leftover to know the what? The one that has been displaced. So if you know the one that has left the bottle, it's going to be the full bottle when you have not pressed, minus what was left over in the bottle. That is the end systolic volume, sorry. The end systolic volume. So it's going to be stroke volume is equal to, or the amount that is dissipated, the amount that fell off is equal to the amount that was what? That was in the whole bottle, minus the amount that left the bottle. Do you understand? Do you understand? So that gives you the what? Lady Zuzu, do you understand? Hello?
Sir.
Do you understand?
Please take us back a bit. Please take us back a bit, sir.
Is that?
Please to take me back a bit. You
Yes,
were explaining the contraction of the bottle and the quantity of the blood spillage out on the left. I want you to emphasize on that. Please, thank you, sir.
Mr. Kwesi Blessing, you raise your hand.
yeah, dog. Please, last week I was not in class, but I'm following the lesson. Does it mean that the volume of the blood that is within is the same as the end diastolic volume, and then the one that is pumped is the end systolic volume?
The one that is pumped away is the stroke volume.
Please come again.
The one that is pumped away is the stroke volume. Do you understand? The one that is pumped away is the stroke volume. The one that is left in the bottle becomes your end systolic volume. So if you can see the slide, stroke volume is equal to 70 mils, right? And your end diastolic volume, the blood volume in each ventricle at the end of a diastole. Diastole is when the heart is what? The heart is filling up, or when the heart is what? Receiving the blood. So the heart has received the blood, and the blood in the heart in the left ventricle is what? 135, right? Then after contraction, the remaining was what? Was 65. So the heart was, when the heart filled up to the full, we got 135. And after contraction, the remaining was what? Was 65. So how much is left? How much was sent away? The one that was sent away is 70 mils. And that 70 mils that was sent away is the stroke volume. Do you understand? Does anybody, any of you understand this thing? Do you understand, Mr. Emmanuel?
Yes, sir.
Do you understand?
Yes, very. Now I understand.
So it means you weren't talking by then. You go. All right. So just use the calculations to see. You see the figures there. They are saying that the stroke volume is what? Is the amount. The reason why I want you to understand this stroke volume is that you are going to use it. Stroke volume will make you know that was the cardiac output. So if stroke volume has a problem, Stroke volume is basically the amount of blood that leaves the heart. That's all. You understand? And we say, how do you know that one? If you are doing calculation, if you are not doing any calculation, just get to know the amount of blood that leaves the heart, the amount of blood pumped by each ventricle with each heartbeat. So if the ventricle pump loved up, that amount of blood that went out, that is the stroke volume. So loved up, 75 becomes what? Becomes the cardiac output, because the stroke volume times what? Stroke volume for what? For 1 minute becomes your cardiac output. You understand? So when we say cardiac output is low, it doesn't mean that the cardiac output is, how do you call it? All the stroke volumes will have to continue for like 75 times before one cardiac output comes out. No. When it's injected, it goes out. But if you want to calculate the cardiac output of the heart, we calculate it in what? In a minute, per minute. You understand? Okay. Mr. Apia, move the slide. Then we talk about ejection fraction. You are saying that ejection fraction is just by expressing the stroke volume as what? As a percentage. That is the amount that left the heart in a form of a percentage. So it's going to be the amount that left over the total times what? 100. So it's going to be stroke volume over end diastolic volume times 100. That is the ejection fraction. That is the percentage of the what? Of the stroke volume. Now let's say, so ejection fraction is what? So if we are calculating ejection fraction of, go to the previous slide, it's going to be 70 over 135 times 100. Calculate it and let's see. So it's going to be what? 70, that is the stroke volume, over 135, that is the end diastolic volume. So 70 over 35 times 100. Right? Calculate for us. What is the answer?
So are we calculating the ejection fraction? If yes, then the EDV, which is the end diastolic volume. Okay, we are doing end systolic volume right now. Okay, so 75 over no, it's end diastolic. So 70 divided by 135 times 100.
51%.
That's 51.
That will give us 51.85%.
So if you want to know the fraction or the percentage of volume that left the heart, that is what 51% of the blood in the heart, in the ventricles left the heart. Do you understand?
Okay.
Yeah. So stroke volume is just the amount of blood that leaves the heart after when the heart contracts. One boom 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 boom. Systolic, diastolic. S1, S2, boom boom. The amount of blood that leaves the heart is a what? Is a stroke volume. Okay, let's go to the next one. Yes, continue. So we say factors that affect the cardiac output. Now we say that cardiac output becomes what? Stroke volume times what? For 1 minute. Stroke volume times what? Times 1 minute. Times heart rate. Yes, and cardiac output equals stroke volume times the heart rate. So if your heart rate is, let's say, your pulse, yeah, that's the pulse. The pulse is, let's say, 75. So 75 times what? 75 times 70. That will give you what? The cardiac output in liters per minute. Do you understand? Yeah, let's have you.
Please, can you go over?
This Kennedy, it involves calculations. So, this is a cardiac output, right? Have you seen? Look on the screen. Look on the screen. The cardiac output is what? Stroke volume times heart rate. The heart rate is just like the pulse, and that one is normally calculated in what? Beats per minute. Right? So we are saying that if you want to calculate the cardiac output, it's going to be what? Stroke volume times the heart rate. And stroke volume is what? Stroke volume from the previous slide you have got to know is what? It's 70 mils. So 70 mils times, and if you are taking a heart rate of, let's say, 75 beats per minute as your heart rate, I mean, as an example, if you are using 75 beats per minute as your heart rate, and the stroke volume is 70, so it's going to be what? 70 by 75, and that will give you the what? The cardiac output in what? Liters per minute. Do you see the unit over there, the one in violet? Liters per minute. I'm sure some of your colleagues do understand. Maybe when we teach in class, you don't understand. Maybe you can just get in contact with any of your colleagues who understand, then we continue. Please continue. So this is what we talked about. So let's talk, and these are some of the factors that affect cardiac output, heart rates, and stroke volume. Continue. So we talked about, continue. It's okay, go to the hypertension slide. Yeah, so what do you remember about this one, to this slide? What do you remember here? Please be scrolling the slide for them so that they can see. Mr. Tete, Mr. Blessing, do you have your hands up?
No, dog.
Then please drop them. Please, this slide too. I mean, what do you remember? What did we talk about? Scroll the slide. Who remembers what we talked about?
Yeah, something related to hypertension.
Yeah, so okay. Give us something to talk. What did you learn the last time regarding this one?
Remember you said hypertension is one of the leading cause of death, especially almost in the world. Almost 1 point something billion people are having it. You gave a percentage of breakdown, half percentage relating to about those who are able to check for it. Half of them are having it, half of them doesn't know. Those who know, half of them are on drugs, half of them are not on drugs. Those who are also, that you gave a half fraction something.
That's very true. That's a good one there. Any other? Charlotte Bokovier. Sister Charlotte. Is she here? Oh, really? Some of you join the class and you go and do your things.
Hello, sir. Can I try?
You said what?
Can I come here? Can I try?
Okay, okay.
All right. What I remember about this diagram is it was about how blood circulation of blood within the heart muscles, especially that there is a vein in the heart called pulmonary vein. That vein carries the oxygenated blood into the lungs. Then it will fill up with oxygen so that it becomes oxygenated. Then it comes back to the heart again to be pumped out into the system. That's what I remember.
So that's very good. But then the one that takes to the artery is the one that sends to the heart, that sends to the lungs. So it's a pulmonary artery that sends it. Then the vein will rather bring it. Okay, vein always come to the heart, and the artery
right.
from the heart. So it's the artery that sends it, and the vein will bring it. That was a good one. Do you get the difference?
Thank you.
Hello.
Yes, sir. Yes, sir. I get the difference.
Right, that's it.
Yes, sir. I get it.
Right.
Hey, but sir,
Yeah.
like in terms of the one that is coming to the heart, the vein. I also know that the veins bring blood to the heart.
Let me call you back. Hold on. Let me pick this call. And there was a question. Someone was asking a question. You were saying
Yeah,
the vein does something. Come again, please.
yeah. I was saying that I think the last time when you were teaching, you said the veins rather carry deoxygenated blood into the heart.
No. So yeah, the vein carry deoxygenated oxygen to the heart. Yes.
But yeah, when the guy was talking, he said the pulmonary vein, which the vein carry the
No, listen here.
oxygenated blood.
Listen here. The systemic veins, they all join into what? Into the bigger vein, which is the vena cavus, the superior and the inferior vena cavus, as you can see over there. Now, when the blood coming from the superior and the inferior vena cavus are coming, they are deoxygenated blood. Then they will get to the heart. Now, when they get to the heart, the pulmonary artery will have to what? Will send them to the what? To the lungs.
Okay.
And when they get to the lungs and they go to pick up oxygen, you see that they are red. And when they are coming back, the vein will bring it back. And this vein is called the pulmonary vein.
Okay. Okay.
The pulmonary vein. Okay. For the pulmonary vein, it doesn't carry deoxygenated. It carries oxygenated blood.
Okay.
But the systemic veins, the one from the legs, from the all parts of the body, before it gets to the heart, is deoxygenated. The oxygen has been sent and has been used up. And so it's coming back to the heart for the heart to carry it to the lungs to pick the oxygen back, give it back to them, then it will be sent back to the cells again. Do you understand?
Okay.
Yeah. All right. That's fine.
Thank you.
You're welcome. We will not forget this one. Yeah. Mr. P, I've been moving the slides. Okay, any other person to talk once again? Hey, the ladies are not talking. Oh, there's one woman who is very, Olumide, where are you? Madam Olumide, is she in class? Olumide, where is she? No, she couldn't join today. Okay, Mr. Kenneth Opoku, are you here? Wow. Mr. Stephen Babite, are you here?
Yes, Doc, I'm here, sir.
Okay. So what did you learn last time on hypertension? When we talked about hypertension, what did you learn last time? BP, about the BP. We talked about BP. What did you learn last time? Mr. Stephen Babite.
Yes, yes, sir. Actually, I learned a few things because by then I was driving. I could not express myself today, to be honest, because I was driving serious on the highway after I was listening. So I cannot go in deeper today. Forgive me, sir.
All right. Okay. Mr. Abdul Wadud.
Okay, so I think the lecture is. So please, let's wait for him to join us. But the question on board was hypertension. How does this really occur? So maybe you can use the definition to find out how hypertension occurs. There tension, hypertension. So you break the word into two. Hyperintention, and then that will help you to easily answer it. It's like the force. You know, when your blood is pumping, it pumps the blood, or when the heart is pumping blood, it pumps it with some energy, with some force. When that force is heavy, it's too high, or let me say it is too powerful. Let's say Mike Tyson is punching someone and I am punching the person. When Mike Tyson punches you, you feel it. But when I punch you, you think I'm joking. So that force, if it's huge, then you are said to be hypertensive. That is why we say hypertension or hypertension. So basically, when it comes, you can use the force that the blood exerts on the arteries, on the artery wall. When it's constantly too high, then it is hypertension. and then we can talk about some of the types. I don't know. I think it's very difficult to join. Let me check my WhatsApp. Please, I'm coming. Okay, so while we wait for Seth to come, you can share ideas before he joins us. He said the link has expired. No, sir. Please, can someone else join? Let me try and join the link and see if it has expired. I'm joining with another phone. It's working. It has not expired. Yeah, Dr. Kunshi, don't say something before the lecturer joins us as we're explaining hypertension.
Oh, yeah. I think what I also, good evening, class. I am traveling, but I don't know whether my network will permit. But let me see. So the other day, we learned that hypertension is one of the most silent killer. And we talk of silent killer. Hypertension is one of them. We talk of diabetes is one of them. So our focus is on the hypertension. So I also learned that, okay, the lecturer made mention we have a lot of people being on drugs on hypertension. A lot of people too, they are not knowing that they have hypertension. So, and we learned that hypertension is the force that exert on blood vessels. We also learned that we have various blood vessels, but the three main one was the capillaries, we have the veins, and we have the arteries. So our focus on the other day was the veins and the arteries, where we said hypertension let me come. We said we also learned that
Hello, I think Sir wants us to join with another link. Sorry. Hello, sorry. Sir wants us to join with another link. I think he's finding difficult to join our link. I don't know why. So he has sent another link. Yes. Okay, he says we should leave it and join this one. Yes, please join this. Okay. Sorry, please exit and join this one. Okay. So please, you can exit. Let's all exit quickly and join the other one.
Chris, is somebody talking?
Yeah, so last time we talked about hypertension, okay? I don't know, but let me ask this question. What we are teaching, is it, do you feel that it's too high for you? I don't know how to put it. Is it too difficult for you? Are there some difficult stuff in it?
No.
I need an answer. Hello. Are there difficult stuff?
No, sir.
Are there too
No,
difficult
No, sir.
stuff for you to learn?
No, sir. No, sir.
Mr. Blessing, put your hand up.
Yes, Doc. This area needs a
Blessing, let's have you.
systematic.
Mr. Blessing.
Yes, please, can you hear me? Hello?
Mr. Blessing, let's hear you. Are you talking?
Yes, I'm talking. Can you hear me, sir?
Teresa, Esther, Adobia.
Adobia. Yes. Please, sometimes it's difficult for me because it's a long time. I left school 71. So this scientific background says sometimes when you are rushing, then it's difficult for me, but I'm trying.
So we talked about the rule of halves. Hey, can you hear me? Are you guys can you hear me?
I can hear you.
Yes, sir, we can hear
Yes,
you.
we
Madam,
can.
see
We
your
can
slide.
hear you loudly.
Teresa, Esther, are you here?
Yes. So I was saying that sometimes.
Is your hand up?
Yes. Yes, Doc. Hello. Good evening, Doc.
So you talked about the rule of halves, 50-50. You said 50 are detected, 50 undetected, 50 treated, 50% of the cases that all hypertensive cases have not been treated. And we say those who are treated to, just about 50 of them are controlled. About 50 of them are not well controlled. Do you understand?
Okay.
That becomes a problem for us to For us to discuss about. Then we also talked about the fact that just about 10% are what? About 25% in what? Less than 25% controlled in what? Developed countries. And just about 10% that are controlled in what? In Ghana and other less developed countries. So it means that in Ghana here, even the 50% who are diagnosed, just about 10% of them are what? Are controlled. The rest are all not controlled. So they will come to a facility with what? With high BPs, and you have to attend to them. We talked about some major cardiovascular risk factors. We said that there are some end organ damages when it comes to hypertension. So the hypertension affects the brain, the liver, the kidneys, the eye, and the blood vessels. All these areas BP can affect. We talked about systemic arterial hypertension and not pulmonary hypertension. We talked about when we're talking about systemic hypertension, we are saying that when you check the BP and it's above 140/90, that is the systolic is above 140, above or equal to 140, and the diastolic is above or equal to 90, then we say there is hypertension. Then we talked about essential hypertension and secondary hypertension. And so when I ask you, you've forgotten all these ones, then there's no need to worry ourselves. Because we talked at length on this one. Mr. Emmanuel, did you record the class? Did you record for last time?
Yes, sir, please. and they've been uploaded to on our YouTube page. Yes,
Class
sir.
rep.
Yes, sir. Sir, I'm speaking. No.
Class rep.
Hello, sir. Please, can you hear me? Yes, sir. Please, can you hear me?
Class rep.
With the mouthpiece, with the earpiece.
Hi.
He's talking. Oh,
Please increase your laptop volume or the phone volume.
Class rep.
Yes, sir.
Answering you.
Sir, please, can you hear from anybody?
Sir, please, can you hear from
Hello?
us? Sir, hello?
I think you should go
Mr.
up and come back
Meboji,
again.
I hear. Is your hand up?
Sir, please, can you hear me?
Yes, please. Yes, please. Please, can you hear me?
Ingrid, is your hand up?
Hear you.
Sir, it appears you cannot hear us. Sir, we can hear you, but it appears you are not hearing us because the class rep was responding.
Can you guys hear me?
Yes, we can hear you.
Yes, we can hear you.
Dog, we can hear
yes,
you.
sir. We can hear you.
Hello.
Yes,
can you hear
please,
me?
we can hear you. Doc, please, can you hear us?
Can you hear me?
I
We
think
can hear you.
his phone might have got a call. If you have a call,
Has
he
anyone
won't
got
hear.
Can you hear me?
We
Yes.
can hear you.
Okay, so it means that he's using his phone, and the moment he gets a call, it will pause. So unless somebody teach you how to be able to on the
No,
the
he needs to
microphone aspect of it.
come out. He needs to come out and come back in.
Okay. Class rep. Mr.
Yes,
sir.
Iman?
Can you
I
hear
can
me
hear
now?
you.
Oh, sorry.
Uh-huh. We've been
So
speaking,
it's
all
from
of
my
us.
side.
We're saying something. Yes, please.
I've been calling and calling and calling. Anyways.
We've also been speaking, sir.
Yeah, we've been
Sorry.
answering and answering.
Yeah, Mr. Iman, did you record the
Yes, sir.
listen? So have
Yes,
you been
please.
sharing
It's
it to
been
the
recorded.
class? Have you been sharing it with
Yes,
them?
it's even. Yes, you can even find it on our page now.
Oh, you are giving me low energy. Oh. Do you
Sir,
get
no,
it?
don't worry. The energy is high. The energy is high.
You're
Just
giving
that
me low
I
energy.
think the majority of us are a little
Serious.
bit tired.
Oh, you guys are tired. Are you tired or something?
Hello,
The
No,
energy is there.
no,
My hand is up.
I've been
No,
wanting to
please.
speak, but apparently you can't hear me.
Because the way you guys started, you were very, very, you were very, very, how do you call, elaborative when it comes to discussions and everything. But it looks like now the vim is down. Oh, it's not down.
Sir, please, there's not down.
Sir,
On
it's
the
because
wait, on the other link, I was trying to explain what you just said.
Because you guys, you are already in the system. So when I talk about something, at least you should be able to give me your observations and some scenarios. You get it. So don't kill the vim because if you kill the vim there, me, I'm a vim killer more than you.
The vim
sir,
is not.
my hand is up.
All right, let's have you, Mr. Mepoji.
Yeah, thank you for the opportunity. Please, it's not that we are not with you. At a point in time, we were talking, you were not hearing us. Some of us wanted to speak, but because you started calling our colleagues by names, we decided to keep mute till we are called.
Okay, now
So
you are.
that's what happened.
All right, now you can now when you want to talk, you can just raise your hand and I'll call you.
Okay.
Madam Ingrid, let's
So
have you.
okay.
Madam Ingrid, let's have you. Ingrid.
No, well, no, sorry, I'm sorry. This time around, I would rather pass because I didn't hear the question and I don't want to hold up the class. I was having difficulty with my Wi-Fi. There was a power outage and the data when I switched to data, it just switched off. So I honestly, I didn't hear the question.
Okay.
So when I put my hand up, it was just to that because you couldn't hear us.
Okay.
Thank you
Blessing.
so much. But yeah, thank you.
You're welcome. Mr. Blessing, let's have you.
Yeah, no, thank you for your tutorial. All that you've been teaching us is well understood. But this particular sport, that is the heart, it's taking us some time to understand the mechanism of the heart. Because looking at the picture on the screen, that will show up how function. This mechanism goes on. Yeah.
Are you talking about this one?
And then how it flows. Yeah, I can see it on the screen here. But the last one you show us is not so clear. So it's taking us some time to understand that mechanism.
Okay.
Thank you.
But even with the way the heart functions, there's a video on your page. There's a video. Mr. Emmanuel, right? There's a video, right?
Yes, sir. I did.
Yeah, there's a video.
Yes, please.
So you watch that video and you understand, okay? Watch and listen to whatever that the video is saying. You should understand with that, okay? All right.
Okay, thank you.
So please keep the energy. I don't like negative energy, else you not make the class lively. All right, let's continue. So I was saying that, last time we talked about essential hypertension and secondary hypertension. Who can remember what we said? Who remembers what we said? If you remember, just put your hand up, I'll call you. Essential and Evans. Mr. Evans, let's have you.
Hello, sir.
Yeah.
Okay, please, can you hear me?
Yeah, I can hear you.
Okay, so we say essential hypertension has no clear reason.
Okay.
But secondary hypertension has a specific medical reason you can find in treat.
Okay.
Yes.
Mr. Ima.
Okay, so just let me add a little to what my brother just said. So with a secondary, it occurs when there's an underlying condition. So let's say you have a kidney disease, you have a diabetes, there are so many, or you are taking some medications, or you are pregnant. So there is a secondary, there's an underlying cause. You have something that is causing you to have your hypertension. And then with the essential, which is the primary one, normally may not really come with any reason, just through your diet or some genetics or the environment, you become hypertensive. Thank you.
I'm now feeling the energy. Because at first I was not getting the energy. Evans, yeah, that's right. That was okay. Yeah. So let's continue. But for the stroke volume and the cardiac calculus and those one, it looks like you guys have used it for you have used it to kill granite.
Now,
no, sir. We understand.
when we come the next time, next time when you come, we will be able to give you back to back.
But you know that one is very important. So you need to know it, because that one is the whole thing. You need it very well in heart failure. You understand? Yeah, you need it. So let's continue.
My hand is up, sir.
All right, let's hear you.
Yeah, with the primary or essential hypertension, you also made known to us that it's about 90 to 95% of the cases of hypertension that we have. And also regarding the secondary hypertension, we have about 5 to 10% of cases.
That's right.
Thank you.
That's right. That's a good observation. That's right. So it makes us know that most of our cases are what? Essential hypertension. Most of the type 2 hypertension that we see are essential hypertension. We talked about the definition. We say what? 140, more than 140, 90. Take notes. For adults, age of what? 18 and above. Right? Then we talked about the stages. Take notes. Stage 1 to stage 3. Right? We also talked about what? Pre-hypertension. When it's between 120 to 139 or 80 to 89, we say we can classify them as what? As pre-hypertensive. So when they hit the 140 and above, and 90 and above, to 140 to 149, 159, stage 1. Stage 2 is what? Anything above 160, 100. We classify it as what? Stage 2. Stage 2 what? Hypertension. Talked about the what? The etiology. Talked about the fact that majority is from what? Environmental and other factors like obesity, hyperuricemia, sleep apneas, environmental factors like sodium intake, alcohol intake, smoking, stress. Then we also have the genetic factors. We talked about the pathophysiology. We say what BP is what? Cardiac output times what?
Peripheral resistance.
Peripheral resistance.
Yeah.
The pressure at the wall of the arteries.
Exactly. So I made you know about peripheral resistance. Peripheral is what? The blood vessels, right? Either the veins or what? Or the artery.
Arteries.
But mostly we are talking about the artery because the artery is the one that is what? That is sending the blood to all parts of the body. You understand? The artery is the one that is sending that one, and is the one that carries the force. That is why when you are setting a line and you mistakenly go and enter an artery, your patient is likely to bleed and die. If an artery is cut, if a vein is cut, then you are going to bleed. But then if an artery is cut, the bleeding is massive because why? The blood is pumping. That one comes with what? With some pressure. You understand? We also talked. So that was where we ended. We ended with the what? With the pathophysiology. So let me just go run through the pathophysiology for you. The very most important one here is the what? Maybe the first three. We'll cater for we'll treat the first three. At least that which you need for this one. These ones are extensive ones, but the first three is what I'll talk about. So we have the what? We have the natriuresis and the renal function. How does natriuresis causes renal function? Let's take note. Do you see you know sodium? Sodium is what? Salt. Sodium chloride, salt, right? Salt contains sodium. So when you say sodium, mostly you're talking about salt, right?
Yes.
Yes. Now we are saying that because of the affinity of salt and water, wherever salt goes, water goes there. Wherever there is salt, water moves from a lower point to where the salt is. Do you understand? So for instance, if the blood vessel, the intracellular, inside the blood vessel, there is a lot of salt in there, you realize that fluid from the extracellular spaces would move into the what? Into the blood vessel. You get what I'm saying? Wherever salt goes, water goes there. Let's put that in mind. Wherever there is salt, because salt dissolves very fast or freely in water, right? So they have some kind of what? Some kind of affinity. So wherever salt goes, water goes there. So we say that what? Constriction of efferent arterioles. With the efferent arterioles, they're talking about the what? The kidneys. So the kidney has the efferent and the afferent arterioles. Efferent arterioles are the arteries, are the efferent arterioles and the afferent veins. The arterioles are the small arteries that will leave the heart. That are leaving the how do you call it? The kidney is what you're talking about. Let me give you a picture so that you understand. So where the filtration occur proper in the kidney is what? It's called the glomerulus. Glomerular, we want to say glomerular filtration. This is the glomerulus. Glomerulus. You see the what? The afferent arterioles and the what? And the efferent arterioles. This is what I wanted to talk about. The afferent arterioles. Afferent is the what? Is the arteries that are entering and the arteries that are what? That are leaving. Okay, these are arteries. Do you understand? We also have the veins there, but we are talking about the arteries here. So we are saying that these arteries, what do? We talked about the fact that the what? Constriction of the what? The efferent arterioles. The efferent are what? Are the ones that are what? That are leaving the glomerulus. Entering the what? Mainly entering the major bloodstream. It's also part of the bloodstream, all right, but that this one is that in the glomerulus. And you know the heart is made up of, the body is made up of several arteries bifurcating from here and there. So this one might have joined a bigger artery that takes part in the whole body circulation. Now we're saying that what happened is that let me go back to our slide. So I just wanted you to see a picture of the what? Of the glomerulus and this is where the ultrafiltration occurs in the body. When we say filtration occurring in the kidneys, this is where the filtration occurs. Okay, this is the glomerulus. This is where the filtration occurs. Okay, let me present something else. So when these efferent arterioles are constricted, if they become very tiny, they become very compressed. If they get compressed, what happens is that it leads to what? Renal blood flow. Guess what? Reduction in renal blood flow. It drops. Look at the arrow. The arrow is showing that it is dropping. Then what? Filtration friction increases. So if the blood flow drops, it causes what? It causes a lot of friction in the what? In the filtration process. Now over here, we are saying that when there is a drop in the renal blood flow, it will result in what? Sodium reabsorption. The sodium that has to be seeped out into the urine tends to what? Tends to be reabsorbed. So when more sodium are being reabsorbed as a result of the constriction of the arterioles, what will happen? It's going to increase blood volume is going to increase. Then cardiac output is going to increase. Why is blood volume going to increase? Because wherever salt goes, water goes there. So when there's more sodium in the blood, it means that more water will stay in the blood because the sodium is what is retaining the water. That is why we tell patients not to take in too much salt. This is the mechanism. Have you ever told your patient not to take in too much salt before?
Yes, sir.
Yes.
Yes.
Why?
Yes.
Why do you tell them that?
As we have explained.
No, before. No, before. Why do you tell them that before?
Hello, sir. Can I speak?
Okay, sir.
Hello, sir.
Yes, sir. Okay, because it increased the volume of the blood in the system.
And that's what?
It increased the volume of the blood in the arteries. That's what we've been telling them.
Okay, so that's what you tell them, man.
Yes.
Okay, that's fine. So the reason why, but you don't even know the mechanism.
Hello, sir. Can I speak?
Okay, you can speak. Yeah.
Okay, so what I've learned is that it dehydrates the blood in such a way that it makes the blood become more thicker for those who have hypertension. So I advise them not to take salt because it dehydrates the blood. And if that happens, it makes the blood becomes more thicker, and it will be very difficult for good circulation happens in that person.
Okay, so it's good you are in class today so that you clear your mind of that, so that you correct the wrong. Okay. Sodium will not dehydrate the blood. Okay. The only way by which your blood you get dehydrated is when you are losing blood or when you are losing fluid. Whatever you are doing that is making you lose fluid. But what you have been telling them today, we have got to know that it's the opposite. Do you understand? Hello, who asked the question? Who asked the question?
Hello, sir. I'm on the line. Yeah.
So I'm saying that today we've got to know that is the opposite of what you are thinking of.
Yes, sir.
Yeah. So it's rather
Can you repeat that again for us?
It's rather when there's a lot of salt in the blood, it causes a lot of salt stay in the blood. Because when you take in more salt, the body will seep out some, but there will be more in the blood. And what happens is that whenever there is salt, there is water affinity. And so fluid will stay in the blood. It will increase the blood volume because ideally, wherever there is salt, water will want to go there. They have that affinity.
Well understood, sir.
So wherever there is salt, there is more blood, there is more water. So that is how come your blood volume will increase. It will increase the blood volume. Why? Because there is salt, and the salt will retain the water. So if there is salt, for example, let's say that you should have sipped out, you should have urinated, let's say 20 mils of water. Now there's a high concentration or high sodium level in the blood or in the kidneys. What will happen? It means that most of the water will be retained there. And so if the water is being retained, you get only about 5% of or about 5 mils just coming out. Instead of the 20 mils, just about 5 mils will come out. So what will happen? If the 15 mils is retained, it's going to increase the what? The volume of the blood. It's going to make your blood more plenty. So if there's a higher volume of the blood, and you know the blood is also made up of what? The blood is made up of what? 60% of what? Majority. No, that's the body. The blood is made up of about 80% of what? Of fluids. And the fluid is mainly what? Mainly water forms part of it. Do you understand? So wherever there is salt, wherever salt goes, water goes there. And so as the water goes there, it's going to make the fluid, the blood in the blood, the water level or the blood in the blood vessels increase. So as the blood volume increase, it's going to increase what? Your cardiac output. Let me pick the questions. Mr. Evans.
Hello, sir.
Yeah?
Oh, sorry, it was a mistake.
Mr. Kwesi Blessing.
No. I understand. I understand as a result of the explanation you are giving that when there is much salt, wherever there is salt, there is water. So there will be a lot of accumulation of water in the body. But I also have a view that when the salt is too much in the bloodstream, won't it cause crystal and then develop some plaques that would narrow the blood path, the bloodstream, not to go flow easily,
Okay,
and
so those,
hence
yeah, I understand. Okay, the second one. Continue.
hence causing hypertension. And also, I want to understand that when you want, when somebody has a low BP, then you can add salt a little bit to add the volume of blood to increase in order to balance the BP condition. That is low BP condition. Thank you.
All right, that's fine. So let me pick it from the down. So yes, when you come to the facility, mostly because something normal saline. Normal saline is made up of what? If you taste the normal saline, it is salty. If you taste normal saline, it's salty. Normal saline. Then the dextrose is sugary. It contains glucose. But normal saline contains what? Sodium chloride. Sodium 0.9% sodium chloride in what? In 500 mils. Normal saline, that is, it's made up of sodium chloride. So it's what? It is salt. It's made up of salt. And it's salty. And we are making it, and we give that one when you are what? When there is hypotension, when your BP is low, you don't go and give dextrose, you don't go and give we give normal saline. So why are we giving the normal saline? So that the sodium will retain the fluid in the blood. In the blood vessels. You understand? The fluid will be maintained, the water will be retained, or the fluid will be retained in the bloodstream, so that to increase the blood volume, so that the pressure will go up. That's why we give the normal saline. You understand? Now, when there is excess salt, it will be found in the kidneys. It wouldn't go and lie. It will lie in the blood, but it wouldn't form plaques like you are seeing. The plaques are formed. They are properties that will make something form like a plague. It will rather form crystals and go and block in the either in the ureters or something like that. But then it doesn't go to line the blood vessel like cholesterol, like lipids do for cholesterol. Okay, Mr. Gracie, bless you. Are you there?
Please come again with the crystal.
So I'm saying that with the crystals, if it forms crystals, you find them in urine.
Okay.
Yeah,
Okay.
you find them in the urine as cast. You see something as cast in the urine, crystals and casts.
Okay.
You find them if you do urinary. That's where you find them. But then even with that, no matter how concentrated it is, you see there is more fluid. So it is very hard for the salt to form crystals. Why? Because what will we do? If it is plenty, it will just be absorbing more water.
Okay.
If it is plenty, the plenty it is to just be absorbing more water, be signaled the body needs water, you drink more water, then it will be retaining it for you.
Okay.
And that is when the edema start to set in. Because when the blood volume is also too much, then it means that oncotic pressure and hydrostatic pressure also has to come in to cause what? Some of the fluid to seep out. Do you understand?
Yeah, thank you so much.
Mr. Amevoji. So now we have the reason why we are going to advise our patient not to take in too much salt. We will not go and say the blood is dehydrated. No. If you say that and the patient go and explain to a relative who is a doctor, he will tell you that your doctor, the one you went to, doesn't know his pathophysiology well. So now we know. Okay, Mr. Mevoji.
Thank you very much for the opportunity. So you were asking why we tell our clients who are hypertensive not to take salt. I look at the stiffness of the arteries because there is too much salt for the explanation you have given. If one takes too much salt at the end of the day, it damages the hypertension damages the arteries, making it stiff. So the elasticity that the arteries are supposed to have wouldn't be there. So many a time, those people who come and complain of numbness and others, I tell them by using the water hose that we use in our gardens and others, that if you buy it fresh and it is very flexible, if you even hold the middle of it by coiling it, water can still flow through. But when it gets hardened and fold it in a you fold a part of it, the water cannot continue to flow. So because of the stiffness of their arteries, that's why the blood circulation becomes poor and they suffer from the numbness and others. That's the explanation I give them. Thank you. If I stand for correction though, if there's something that you can add to enhance my knowledge, it will be welcome. Thank you.
All right, that's fine. I mean, your analogy. I mean, you're not far from right. But I mean, but then it's not really on point like that. Okay, for handling of the blood vessels, mainly it's about the minerals. Okay, potassium, magnesium, calcium. They are those that bring about the hardening. Now, now we are talking about even how will the blood pressure go up? What will cause the blood pressure go up before it's going to affect the arteries? That's what we are talking about. So it is the volume. When the volume is up, when the blood volume is up, it is going to increase the cardiac output, and the cardiac output is going to cause what? High blood pressure. If there's a high cardiac output, there is a high blood pressure. And how did the high blood pressure come? Because there was what? Some sodium retention. And the sodium retention also retained water. And when the water was retained, it increased the blood volume. When the blood volume was increased, it causes what? It caused the cardiac output what? To also be high. And when the cardiac output is high, there was high blood pressure. Do you understand?
Yes, please.
All right. So I mean, you can be explaining like this to them. If you go by this one, I think it should sit down well with your clients. Okay. Please give me 1 minute. Let me sort someone out. Yeah, so that is for sodium, and I mean how sodium causes water to blood pressure to occur. Okay. Ingrid, is your hand up? Madam Ingrid, is your hand up?
Yes, it is, please. Can you hear me?
Yeah, you can talk.
Okay, thank you. So the internet has been acting up today. Yes, thank you. Thank you for this very interesting topic. And hypertension is indeed a very widespread affliction worldwide. So one of the things I wanted to comment on is salt. Now, there are different types of salt. The salt that people usually think of when we talk about salt is what we call table salt. That's a free-flowing salt. Popular brand of salt in that blue box, and that salt has only sodium in it. The other salts, for instance, the like the Himalayan salt, those salts have other elements in it, other nutrients in it that the table salt is stripped of, and because it is stripped of it, the sodium. In fact, if you look at table salt, the only element listed is sodium, which is very bad for you. Now, the other salts have a whole lot of stuff, like as you mentioned, the magnesium, the potassium. It has 8 minerals in it, and the table salt that we use has none of those 80 minerals in it. So it takes more when the same volume of salt that you take from sea salt and Celtic salt and Himalayan salt, the same volume, that same volume that is used with the table salt, is totally the table salt is totally stripped of all the nutrients in it. Plus, not only stripped of the nutrients, it has added elements in it that are not good for the body. That makes it that free flowing, and that makes it. Some of it is even they say it's powdered, what's that, like powdered glass, really. That's bottom line what it is, silicone in it, which amounts to glass that is flowing through our veins, through our arteries and veins, which is not good for us. And so for people that I have got a few people off hypertension and hypertension medication, one of the things, the first thing is to stop taking table salt and to switch to a natural salt, like the salts that I mentioned before. So I wanted to mention that and to hear your comment if you think what you think about that. Thank you.
Yeah, so that's a very nice, addition that you've made. Yes, naturally with the salt, so you see, like we were saying, the table salt. Normally, we always encourage them that in situations whereby you will have to add an additional salt to your food, whereby this salt has not gone under any processing or nothing at all, you just add it and it's going straight to the body. It has high affinity of what? Of reabsorption of what? Of fluids. Normally too, there are some food contents that already contain or would contain some amount of salt. For instance, our fishes and our some of the fishes have salt content in them and all those ones. Some of the seafoods also are salty. Yes, those ones aside. So those ones are also giving us, if we take them, they are giving us they are being converted into the sodium that we're talking about here as the salt. Then also we adding up on table salt too as well. So it becomes, problematic. It becomes too much of an overdose for us, whereby we after preparing the soup, it's very common when you go to in Ghana we have what we call the chop bar, and almost every chop bar there is a table salt on the table, and majority of the people that go to the chop bar are men, right? And when our men go there, what do? They add salt to the food. So there are some people who have been eating at the chop bar for over 15 years. So you can imagine. You can imagine. There are some people who eat at the chop bar, on a regular basis. Maybe they take their lunch at the shop or at the restaurant where salt is served. And he does this, he's been doing this continuously, subconsciously for over 15 years now. So if this person is getting BP, he might think that he might not really know where it's coming from. He might think that, oh, it's something small, but we say little drops of water makes a mighty ocean. You understand? So I think that's what I also add to it. So yes, the table salts also play a role. I mean, they are actively causing the high BPs. Yes, you are right.
Doc, I have a question.
You are the one I was waiting for, Madam Gladys.
Thank you, sir. Please, as you are studying hypertension, I want to ask a question. That since you know the causes of hypertension, but there are some people who are having hypotension, and I want to know, is it natural because something caused hypertension? Then those with hypo, is it natural? Is it how God created, or maybe as the result of what they have eaten, the causes of the hypo, and how do we handle it? Is there any treatment on that?
Okay, so that's fine. So naturally, some people have low BPs. Some people, theirs is natural. They naturally have low BPs. No matter how you check their BP, their systolics are mostly below 60. Their diastolics are mostly below 60. Their systolics are mostly below 100. So you get like something like 90, 50 something, and they are working normal. They are fine. You understand? That is naturally their BPs are low. Okay. And there are some situations whereby people go into hypo. For instance, someone is vomiting, or someone is bleeding. Someone is having this how do you call it? Has a how do you call it? A fibroid and is bleeding. I mean, someone is anemic. Someone who is anemic. Someone who is how do you call it? Yes, has maybe vomiting with diarrhea. Their BPs go down. So hypotension can be an acute and also can be more like a chronic one. The chronic ones, they are used to low BPs. I mean, they are naturally hypotensive. You understand? They are naturally they don't have high BPs. That is it. You check their BP, their BPs are low and they are fine. That is how their heart is functioning like. Bear in mind, we say that 120/80 is the average. It doesn't mean that everyone should get to 120/80 or below 120/80. Some are 90/60. Some are 90, 95, 80 something, 50 something, but they are fine. You understand? So that is it.
Is it not that because if it is hypo, nobody knows to go below what they are having, just like the hyper, when it goes high, more than the expected, the person can die. Then the hypo people too, are they not at risk?
Come again, I didn't hear that.
I'm saying that
I can't hear you. I can't hear you.
Hello, can you hear me?
Come again.
Is it okay now?
Yeah, it's okay.
Okay, so what I'm saying is, those with natural hypo, is it not a risk? Is it not risk? Are they not a risk? Because those the high BP patient, when it is too high, it can cause one to die. Then those with hypo, and nobody know when it will be lower than what they are having. How do you advise on
that is their natural one. Their body is used to it. So with them, when they even hit 130, it becomes high for them, and they will begin to have manifest symptoms of hypertension. They are used to natural hypotensive. Their BPs are low. So when this person moves from 90, 50 something and comes to, let's say, 130, 80, this person's BP is going up, he will tell you that the BP is up because his BP is around 90 something. So that is their nature. Their body and their heart is used to that. Do you
Thank you.
understand?
Thank you.
Is there any other question?
Yes, sir.
Madam Eunice Tonye.
Yeah, please, good evening. Please, I have two questions. The first question is, I wanted to ask if overhydration can also cause high BP. And secondly, if a patient has a low BP, can you advise the patient to take enough salt? Thank you.
Okay. So with the part of the person having low BPs and taking enough salt, we don't want to introduce salt to the person, and the person will think that, oh, doctor said I should eat salt, I should eat salt. Just tell the person to be taking more water.
Okay.
The water also increases blood volume. But just that in hypotension or in state of hypotension, we give the sodium to retain more water. But if you don't advise the patient to be taking more salt, now they will be eating more salt, and maybe in the end it would result into something else.
Okay.
So we just advise them to be taking more fluids, to be taking more, hydrating
Okay.
themselves. Okay.
Okay.
The second question is what?
The second question is overhydration. Like people who takes in more than required amount of water, can that also increase the blood volume to cause hypertension?
Oh yeah, I mean it's not like, I mean the body has a threshold. Everybody will take in more water, and there's nothing like it wouldn't overhydrate them. Naturally, if you take in more water and you are full, the body will let you know that you are full. You know this? Oh, boss man.
Okay.
Yes, sir. You are consulting your wife. Ah.
Madam Eunice, please.
Please, I had a meeting from before. The class was rescheduled, so I have to leave now, please. So Dr. Bach, you could explain just in case it comes up that I'm not here. Thank you.
Okay.
Thank you.
Okay.
Yeah.
Well.
Good evening, everybody.
Hello, class. Please, are we on water break? I went off. I just came in and everything is
We are
silent.
not on water break, but I think the lecturer is having a discussion with someone. So please
Okay,
hold on.
thank you very much.
Yes, sir. Good evening, sir.
Yeah, please, your hand is up. You have a
Yes,
question.
yes, sir. Yeah, for your presentation, you made mention of someone naturally has this hypertension,
Yeah,
low BP.
yeah.
And I want to know, how can you know that this person, his own is natural?
Oh yeah, so it's been consistently for some time.
Okay.
Consistent, and there's not giving them problems. Anytime they check, it's low. Anytime they check, is that's how it is. Their BPs are low naturally. That's how it is. You will not check their BP and get like any high BPs. And the patient is also not complaining. They go about their normal activities. They are fine, no problem, nothing at all.
Okay. Oh, okay. All right. Thank you very much, sir.
Yeah. Yes, Mr. Charles Menu.
So, sir, please, my question was about the hypertension. So that means hypertension can never be described as a disease condition.
Okay. Hypertension can be a state. It can be a state. It cannot be. We don't classify somebody as hypotensive. So we are giving person medications and coming for. It's not worrying them. Those who are naturally hypotensive, it's not worrying them. And those who are, I mean, normotensive, who have a normal BP and go into hypotension, they normally would show some signs, and so we'll come to the hospital and we give them some what, some IV fluids to what, to cater to I mean to bring them to their normal level. You understand? But then those who have low hypertension, we don't classify them as diseased. Do you get it?
Because, yeah, I get it.
Ideally, we
Because
want the BPs.
sometimes,
Ideally, listen here. Ideally, we want the BPs to be down. So if the BPs are down already, that's okay. And if they are okay with it, it's not worrying them, nothing at all. It means that that is their BP. That is their natural BP. It becomes a problem when it goes beyond or it goes up.
okay, okay, sir. I get it. Thank you.
Yeah. Uh-huh. Yeah. Is that all? Okay, let's continue. So that is it. Then we also have one we call the Renin-Angiotensin system. The Renin-Angiotensin system. So when you see this one, we are saying that there's another system. That one is about the kidney and the blood vessels. Okay, so you see this one. These are the kidneys, and these are the suprarenal glands. That is the adrenal glands. Okay, these are the kidneys. You see them? These are the two kidneys, and this is your liver, right? What do you see here? There is something produced from here. Produced from here. What do you see? This is all renin. It's a hormone that is being released by the kidneys into the bloodstream. You understand? And the liver also produces another hormone called the what? The angiotensinogen. You understand? What happened is that the renin, this renin here, is what stimulates the production of what? Angiotensinogen. The angiotensinogen is a hormone that is being produced by the what? By the liver. So this one, renin stimulates the production of angiotensinogen. Then it converts, it helps for angiotensinogen to be converted to what? Angiotensin 1. These ones, they are their names, so I don't know why they call them that, but it is from the inventors. They give them those names. So renin produced by the kidneys. So that is why we give some drugs that are catering for focusing on what? On the kidneys. And that is also why when somebody has a kidney problem, there is what? There is high BPs. The BPs go up because why? This renin, you see, the reason being is that the renin here is being produced by the kidneys. Now, what happened is that the angiotensinogen being produced by the liver will be converted to angiotensin 1. That is, let's say, a refined form or an absorbable form of it. You understand? Now, this angiotensin 1 is being converted from angiotensin 1 to angiotensin 2. You understand? But then we are saying that in situations like that, this angiotensin 2, we don't want to reach here. We don't want the angiotensin 1 to reach to angiotensinogen. The angiotensinogen is more like the enzyme that will convert this to this. But we don't want the angiotensinogen to reach the angiotensinogen 2. Because what does the 2 do? The 2 is what? It's a vasoconstrictor. So you see, so angiotensinogen to angiotensin 1. Then we have angiotensinogen 2. AC is in the lungs to angiotensinogen 2. Then angiotensinogen to aldosterone. Then aldosterone what? It's a renal retention of sodium and water. Let me explain this one to you. So the renin here converts the angiotensinogen to angiotensin 1. But then we do not want it to convert it to angiotensin 2. Why? Because the angiotensin 2 is what? It's a vasoconstrictor, vascular hypertrophy, and renal retention what? It also leads to what? Renal retention of water. So we are preventing the conversion from what? Angiotensin 1 to angiotensin 2. That's why we have a BP drug we call the ACEIs, angiotensin converting enzyme inhibitors. Angiotensin converting enzyme inhibitors. And what do? They prevent angiotensin 1 to what? To angiotensin 2. You understand? They prevent angiotensin 1 to angiotensin 2 because the angiotensin 2 is what? It's a vasoconstrictor. What would a vasoconstrictor do? If there's a vasoconstrictor, if it constricts the blood, it's going to make the blood vessel tiny. So when the blood vessel is tiny, there's going to be what? High pressure. Then vascular hypertrophy. If vascular hypertrophy is going to make what? The cells of the blood vessel or the tissues of the blood vessel will enlarge, will swell up or will become bigger. So if it becomes bigger, the lumen becomes smaller. Do you understand? The lumen. For instance, if you have a pipe and then you subject the pipe to heat.
Yes, sir.
If you subject the pipe to heat, the body of the pipe can be affected, can swell up, but it might also what? Reduce the channel. It will occlude the channel. Do you understand? Do you understand? It will what? It will do what? It will occlude the channel, and that is it. Then we also have the renal retention. Now the angiotensinogen 2 also goes to what? Stimulates the production of what? Aldosterone. aldosterone, stimulate the production of what? Aldosterone. 2, and the aldosterone is going to cause what? Retention of urine, of sodium and water. So the advent or the production of aldosterone or the release of aldosterone will cause, the aldosterone is also a hormone, mostly at the posterior pituitary. Is it anterior? Yeah, the posterior pituitary gland. Yes, it's being stimulated from the posterior pituitary gland to cause what? To cause renal retention and sodium and water. So these are some of the mechanisms that will cause what? High blood pressure. So it is, we say, the Renin angiotensin system, whereby renin is being produced as a hormone to prevent angiotensinogen into angiotensin 1. If it doesn't occur, then angiotensinogen is being converted to angiotensinogen 2. Now the angiotensin 2 is the deadly one, because that is what causes vasoconstriction, vascular hypertrophy, renal retention of sodium and water. Give me 1 second. Let me connect my battery, my charger. My machine is going off. No, it's not charged. Why the phone for? It's not charging. Press the power button and listen. Press the power and listen. It's charging now. The home color is coming. The home color that should be coming. So you put it there, listen. Press the power button and listen when it's on. Yeah. So that is it. I mean, bring your questions. If you don't understand anything, let me see your questions. So we are saying that the renin-angiotensin mechanism is ideally to what? Ideally, if nothing happens, if there are no medications given, it is going to what? It's going to increase the blood. Now don't forget, we are talking about hypertension here. So the renin is being stimulated, it's being released to have the conversion of what? Angiotensin to angiotensin 1, then angiotensin 1 to angiotensin 2. And angiotensin 2 is what? It's a vasoconstrictor, a vascular hypertrophy. Then also the angiotensin 2 is also stimulated what? The release of what? Aldosterone. This aldosterone is really okay. So the aldosterone is, so you can see from here, released from what? From the suprarenal glands. That's the adrenal glands. To put adrenal glands into the what? Into the bloodstream. And what happens is that it's going to cause what? Sodium and what? Water retention. So if there's sodium and water retention, what will happen? When there's sodium and water retention, what will happen? Oh, my people. When there's sodium and water retention, what will happen?
Blood volume increase.
Blood volume increase, yes.
Blood volume increase, yes.
Then cardiac output also what? Also increases. When there is vasoconstriction, what will happen? When there is vasoconstriction, what will happen? Hello, look at the slide. When there is vasoconstriction, what will happen? When there is vasoconstriction, what will happen? there's going to be peripheral resistance. Peripheral resistance will increase. Do you understand? There's going to be increase in peripheral resistance. And I told you that BP is equal to cardiac output times peripheral resistance. So when there's a higher peripheral resistance, it means that there's going to be what? A higher BP. Right? Vasoconstriction. When there's vasoconstriction here.
Yes, sir. Yes, sir.
When the blood vessels are constricted, so when we say constricted, like it's like pressing the bottle. When the bottles are pressed, what will happen? Pressure goes up. You understand? There's going to be a lot of pressure here. There's going to be vasoconstriction. Do you understand? When there's vascular hypertrophy, the cells of this one are what? The cells of the blood vessels are what? Are swollen up. Are swollen up, are increasing in size and in cells. The lumen is going to be smaller. You understand? And so it's going to increase the blood pressure. Any question? What physiology? It looks like it's over you people pound. But it's simple to. It's easy to explain. It's easy to understand. Though. I mean, it's new to you, so don't worry. And we talk of the sympathetic nervous system. I think I have to be slow for you because it looks like let's explain. Next time I'll go through the slide again. So we talk about the sympathetic nervous system. I told you last time that it is the what? It is the fight and flight state, right? Fight and flight. When you see the sympathetic nervous system, we are talking about what? Fight or flight. It's like seeing a cat. Seeing a lion. Seeing a lion here and a cheetah here. What do? You have to take to your heels. Even though your heels cannot help you, because they will obviously catch you and devour you, but still you run because it's scary. At that moment that you are running, the energy that you got to move, at that point, the sympathetic nervous system has taken over you. Right? So we say that there are two hormones, the epinephrine and the norepinephrine. What do? They cause what? Myocardial contraction to increase. When the contraction increases, what will do? What will happen? It will increase the heart rate. Yes. Hi. Good evening. I'm fine. Good. How are you doing today? You are better. Are you done with the medications? All right, that's fine. All the best. Take a shot and send to me. Fine. All right, that's fine. Yeah. So when the cardiac contractions are high, it's going to increase the heart rate. Do you believe that? When the contractility is high, when the heart is contracted, what will happen? It means that it's going to pump more. Higher contractility means a lot of what? I mean, it's going to increase, how do you call it? It's going to cause more blood to be, it's going to increase the stroke volume. Because higher contractility, higher the stroke volume, right? Do you believe that? The higher the contractility, the higher the stroke volume. Hello? Oh.
Hi. Yes, sir. We understand.
When I'm saying something, that is why I gave you the bottle as an analogy. Use the bottle as an analogy. If I press the bottle hard, what will happen? A lot of what? Fluid will come out of the bottle. But if I massage the bottle, what will happen? Something small will come out.
Yes, sir.
If I press it and squeeze it very well, I'll get more blood out. So it's still as here, the contractility. If there's higher contraction, there's a higher stroke volume. You understand? And as the stroke volume is higher, we are talking about the heart rate also. It's also going to increase. Because you are contracting the more, the body would sense that you are contracting, more. So still the heart will also be pumping faster. Because there's more contractility. So higher contractility, higher heart rate. So higher contractility, higher heart rate will cause what? Higher cardiac output. And when the cardiac output is high, BP is what? BP is high.
It's very high, yes.
The cardiac output, the cardiac output should have a range, should have, let's say if the cardiac output should be like, let's say it should be like 50, and now there's higher cardiac output around 70, 80, there's going to be high blood pressure because the heart is beating fast. It's pumping more than it's even needed. You understand?
Yes, sir. Hello, sir.
Yeah.
So, sir, can you explain how the renal stimulate the hormones released by the liver again? Please, can you go over that one? Because I'm not getting it when the hormones released by the
let me get a note on that. It looks like this one. I'm just explaining. I'm just using the slide to explain. I'm coming. Ask your question. I'm listening.
Okay, I just want you to go over that one again, so that, because what I'm not getting is when more blood is pumped, does it mean you did mention of hypertrophy, which means the blood vessel or the cells will, how do you call it? The blood vessels will expand, or it will grow bigger. Does it mean if they expand and adapt, does it mean it's going to increase blood pressure? Because I'm not getting that as well. That's what I'm saying. I should go over it.
Okay, I get you.
Yes. Sir.
Now I was with the vascular hypertrophy.
Yes.
I was talking about. I'm coming. Let me give you a picture of that, so that you appreciate it. Okay, this one is ventricular hypertrophy. This one is with the muscle. Coming. I want to give you a picture of that, and you see. Okay, let me use this one to explain the mechanism of hypertrophy for you. Look at this. You see, the cells are what? Hypertrophied. Well, we have two types of enlargement. We have the hyperplasia and hypertrophy. Hyperplasia is what? Is when the cells are increasing abnormally in size. The cells are multiplying up. And hypertrophy is when the muscle or the cells are what are enlarging. They are enlarged. Now look at this one. If this one were to be if this one were to be a what? Imagine this one as what? As a blood vessel, and there has been a hypertrophy, a vascular hypertrophy of the blood vessel. You see the edges of the blood vessel are what? Are enlarged. But then look at the lumen. You see the channel where blood has to pass.
Yes.
Yes. You see where blood has to pass. So if blood is passing here, won't it go with pressure? Will it not go with pressure?
Yes,
Because
it will.
Good.
the smaller the area, the higher the pressure. You understand? For instance, if you are pouring sachet water through a tube, and you are pouring that same sachet water through a barrel, which one will have a higher pressure? The tube will have a higher pressure.
Yes, sir.
You understand? So that is vascular, that is the hypertrophy I'm talking about here. And if that occurs, it's going to cause the BPs to go up. You understand?
So that means it affects the walls of the blood vessels.
Exactly. And it can cause what? The blood vessels to what? To enlarge. Look at this one. Do you see the difference? Arterial hypertrophy. You see this one? There is what? There is a bigger space. Look at here. You see that the what? The body of the blood vessel is getting bigger. Do you understand? And so the lumen is getting smaller. And over here, the lumen is small because the body is big. Do you understand?
Yes.
This is it. So you see, look at this one, and look at this, and look at this. So this is vascular hypertrophy. So if this one is highly hypertrophied, because look at the lumen, and look at this one's lumen. So with this one and this one, if you have this and somebody has this, who will have more pressure? Is it not this?
Yes.
Is it not this one? Yes, there will be more pressure in this one than the one who have with what? With the smaller one. So the body, the higher the body or the larger.
So I can't see your screen.
Oh, how? You can see
I can
my
now
screen?
see it. I can now see it.
So the higher the this one, the body, the hypertrophy, the smaller the lumen. And so as the smaller the lumen, the larger the higher the BP, or the larger the pressure. Kate, I call. Madam Kate, I call. Madam Kate.
Yes, sir. Thank you very much, sir. Asking about the stroke volume. When the stroke volume is
what?
Magnetic analyzer I use, most often the stroke volume is low. And because I have limited knowledge,
Oh, I can't hear you.
Hello, sir.
Yeah.
Please, can you hear me now?
Yeah, let's hear you. I think you'll be the last person. Yes.
Okay. was just asking about the stroke volume again. I normally use the quantum resonance magnetic analyzer for screening. And honestly, today I've been enlightened because the way I normally explained it, I see it is quite the opposite. But most often when I check people, the stroke volume is always low. So please, I want to understand what happens when the stroke volume is low.
What you say when you check for people, their stroke volume is low.
Yes, at times the stroke volume is low when the vascular resistance and the vascular elasticity is high. You see the stroke volume at times is low.
And so when there's higher vascular elasticity, like we talked about factors affecting the stroke volume. The venous return, do you remember? We talked about the venous return. So if there is higher elasticity, if there is, where is the slide for the stroke volume? Mr. P, I shared that slide. So when let me explain to her. When there is peripheral resistance or whatever, or there is a pressure there, it means that the stroke volume will be low because there is no proper filling. The filling is not enough. I made you know that the end diastolic volume, it can be that the end diastolic volume is not a full bottle. So if it's not a full bottle, before you contract it, good. Go up, come down, come down, come down. Okay, then. Okay, that's fine, that's fine. So factors affecting the stroke volume, the preload and the afterload, then the myocardial contractility. Let's look at the preload. When we are saying that when the filling is not even a full bottle, that is the preload comes about with what? With venous return. So when there is obstructions in the blood vessels causing a blockage and no proper venous return, it means that small amount will return. And if small amount will return, it means that only small amount will be pumped out. For instance, let's say about 50 mils have to return, and because of this venous resistance or arterial vascular resistance, 20% or 30 mils came. When 30 mils came, it came into the blood, and now ideally it should be around 50 mils that has to go back. Or let's say the heart should at least pump like 50 mils. Now only 30 came. And let's say there was 20 left. If it contracts, maybe the contraction is not even strong. It will be only 30 mils that will go, or even 25 mils that will go. So when there is poor venous return, stroke volume will be low. Madam Kate, do you understand?
Yes, sir.
When there is a poor venous return, stroke volume will be low because there is what? A resistance that is preventing the blood from coming to the heart. So if the blood doesn't come to the heart, if small comes to the heart, small will go out. Do you understand?
Yes, sir.
All right. Yes, sir. Any other question? So now you get an explanation on how to explain to your client, right?
Yes, thank you very much, sir.
Right, right. Any other question? We are ending the class here. Any other question?
Yes, sir.
Yeah.
To my understood, I think all these vessels, example to my faith, it's like a car that you have the water tank blocked and it could not circulate well to all the return pipes, and due to that you get overheating, and the whole some of them as a returns or intake hose will go best, and some of them will be narrow because the fins of the tank were dirty or choked. Due to that can cause you high blood pressure in your veins compared to The radiator I'm talking about, as your own car, we call it FIMS. The FIMS is choked, means that to cause overheating, to cause a lot of havoc in the system. Am I right? This is my understanding of your explanation. I'm an automobile engineer, so I took that concept to the understanding of your explanation. Thank you, if I'm right.
You are very right, my brother. You are very right. That is it. Any blockage is going to cause a problem. And so in the car, it will show up as what? As overheating. Because there's no proper blood there's no proper water fluid that is cooling the engines for us, for you, right? So you are right. Any other person?
That is consent.
Any question?
Yeah, hello, sir.
Yeah.
Sir, a hand is up.
Hello, sir.
Yeah, let's hear you.
Okay, thank you for your lectures. Actually, at a point when you were lecturing us, you wanted us to respond for you to see if we were following you. So, actually, we are many in the class, and some of us, our background are very, very noisy. And then what I would say is, all of us are actually following. If we are to unmute our mics and then respond like, yes, sir, we are following, yes, sir, it's going to cause chaos at a point. So what I'm trying to say is all of us are following. So whenever you want us to respond or something like that, we can actually send emojis or something
Yeah,
for you to see it.
that's what I actually want from you. It's the emojis I want, not your voices. It's the emojis I
Okay.
want.
All right. So
Yeah,
next
so
time
when if I
we will
see
do
the
that.
thumbs up, I know you are following. That's all.
All right. I hope I'm actually talking on behalf of the class, or the
Yeah,
class is talking on behalf of me.
that's fine. We get you, Mr. Stephen Pabite.
Yes, the dog.
I don't know who spoke right now.
No, sir.
No, it's Dr. Strange.
All right, then let's hear you. Mr. Kumsin Daniel.
Okay, sir. Thank you, sir. So my network was not that active, so I don't know. My understanding of today's lesson is about how it's talking about how the walls of the blood vessel being expanded itself for circulation. Is it about that?
Yeah. When the blood vessels are stretching and they are enlarging in size, they make the lumen narrow.
Okay. Okay, sir. Thank you, sir.
All right. Mr. Champon Eric. Okay. Mr. Menu Charles, is your hand up?
Yes, sir. So what I have also learned is about the angiotensin 2. You said it is a major cause of the hypertension. So it normally it normally increases the volume. Yeah, it normally increases the volume of the blood, and also that is what I have known for now.
Okay.
Thank you.
Said that it's a vasoconstrictor. What does vasoconstriction means? It constricts the blood vessels. It makes the blood vessels what? Smaller. It makes the blood vessels constricted. It makes the blood vessels how do you call it? Squeezed up. So when the blood vessel is squeezed up, it becomes like this. It becomes like what I showed you. It becomes not like this. The other one, I showed you some other one before this one. makes the blood vessels squeezed up. When the blood vessels are squeezed up, their lumen becomes smaller, and constriction will increase contractility. You understand? It will increase contractility and can cause high BPs. Okay, so you are right. Is that all? Any question? Any other question? A champ, Henrik, is your hand up? Any other question?
So my hand is up.
Let's hear you.
Please, I need a little clarification on how somebody's blood pressure will be high, but the heartbeat or the heart rate will be low. For example, I tell somebody the systolic was 165, the diastolic was 96, but the heart rate was 55.
It's wrong. The machine.
What might have been
the machine is wrong.
Please, it's not only one machine. No, I tried. The person has gotten his own machine. I use that, and I use my own machine. I use 2 different BP apparatus to arrive at that.
He said that the heart was what? The heart pressure was what?
The systolic was 165. The diastolic was 96. And the heart rate was 55.
Oh, okay.
So my question is, what might have been the cause in such a case?
You appreciate this one better when we get to heart failure. Okay. But the reason being is that, for all you know, maybe this person's BP can be from what? An underlying condition. Maybe he has a heart problem. That is how come maybe the BPs are like that. Also, in situations of the heart failing, what happens is that when the heart continue to beat and beat and beat, it tends to what? It tends to get tired. So when the heart is, in a state of heart failure, you realize that the BPs will be what? The BPs will be up. You understand? Systemic BPs will be up, all right. But then the heart is now weak, so it's not able to pump blood as it is. But those ones, they rarely occur. It's just in some few cases. So that's what I'm saying, that let's leave it for heart. When we get into heart failure, you appreciate it better. But then it's more like a heart failure condition.
Thank you very much for the reception, sir.
All right, that's fine. Any other person? Any other person? All right, then we'll call it a day here. Then we'll meet next week. Within the week, I'll require you to do your project works and this thing. So I'll put everything in the page. Okay. All right. Have a good night.
Bye-bye.
Bye.
Thank you.
Bye-bye.
God bless you, sir.